Welcome to What Brought You Here Today, an interview-style mental health podcast that focuses on real experiences and how we navigate and move through them. The guests on this show provide personal and professional insight at times and come from all walks of life. Not all of the guests work in the mental health field, and they've all chosen to be brave and vulnerable while sharing parts of their story with you. Please keep your own mental health and well-being in mind while listening. The topics in this episode are sensitive. If you experience any distress while listening, please pause and return at a later time. Please take care while listening. Hello, everyone. Welcome back to What Brought You Here Today. My name is Ryanne, your host, and today I am joined by Maggie Duret. She is a licensed professional clinical counselor here in Minnesota, and we are going to talk all things OCD. I'm going to let Maggie introduce herself, so thank you for being here, and go ahead.
Yeah, thank you so much for having me. My name's Maggie Duret. I'm an LPCC licensed in Minnesota. Just through the counseling compact, got some privileges to work in Arizona as well. I own a private practice, Northlight Counseling, where I specialize in treating OCD and anxiety disorders. I do virtual and in person. My in-person office is in St. Paul, and I'm just really passionate about treating that population and have some personal experience myself with those conditions and disorders. So that's kind of my thing.
Thank you again for being here. We should have talked about this earlier and planned this better. We're just right down the road from each other. We're
awesome. That's
in
great.
St. Paul. Yeah, I'm just over here up on the hill a little bit, so not too far from, I'm sure, where you are in St. Paul, but
right, exactly.
Anyway, yeah, let's just dive in. What is OCD?
Man, OCD. Wow. So, OCD, first of all, it's important to say what it's not. So, there's a big stigma. OCD is not being very cleanly. OCD is not being very organized, and OCD is not an adjective. So, I'm so OCD, or I'm so OCD about this or that, or I have OCD because I like to be organized or I like things a certain way, right? That might be something else clinical, but it's certainly not OCD. So OCD is the presence of obsessions and or compulsions, although almost all of the time we see both, that are so distressing and so looping in one's mind and one's life that it really causes a lot of clinical distress, a lot of social functioning distress, relational functioning distress can get all the way from, bothersome to extremely upsetting for people. So, and oftentimes, it has absolutely nothing to do with being organized or anything like that. The content of the obsessions can be violent, sexual. They can be about your relationships, about your children, about who you are as a person, about the world, about politics. They can be about literally whatever you could possibly think of. OCD can latch onto that and convince you that you need to do compulsions to be safe. And it's extremely debilitating, and it makes it easy to be passionate about educating people about what it is and then also treating it, because otherwise can go untreated for a really long time.
Yeah, which I think now, I feel in the last couple of years particularly, there's been a lot of clarification around what you're saying in terms of what OCD is not, and how do we get people to the right place to get the appropriate clinical diagnosis for the symptoms they're having.
Yeah, absolutely. And I know I'm embarrassed of my earliest therapeutic work. How many people did I maybe misdiagnose with generalized anxiety or even maybe a specific phobia or, just the misdiagnosis because I myself wasn't trained and to really understand and recognize OCD. So I'm sorry to all those I may have misdiagnosed. And also, I think it just shows that there's a disservice even among professionals to really understand what this is so that we can treat it competently and specifically, because really important to know that talk there can not only not help, but also can make it worse.
Yeah, which I think is also new for a lot of clinicians out there, right? Thinking they've been doing a lot of good work and in reality may not have been, which is so heartbreaking as a therapist and frustrating.
It breaks my heart. It breaks my own heart to think of the work that I did. And I think it's important to say too that supportive therapy is important, right? Supporting people, validating people. And, when you know better, you do better, right? And so now that, we have more information on it and more resources about the specific evidence-based treatments, now we can do better and direct people. I've had such amazing clinicians within the cities direct people to me and say, this is out of my hands, and I really think you should see a specialist. And we've collaborated together so that they can get support from another clinician, but, then really see me to target those OCD concerns. I mean, it's just been really awesome to see the collaboration and the understanding among professionals. And I'm doing the same, right? If there's something outside of my scope, I'm sending them over there. I think there's a beauty to specialization. It's really, I think it's too much to ask us as clinicians to know everything about everything. There's so
Right.
much.
Right. Right. And to just be able to effectively treat people, right? When you're kind of when you're like doing more general work, I think that can work for some people and in certain circumstances, but it won't work across the board.
No, no. And I think many times, those general therapists can be the best people to refer, right? To see someone, to assess, to get a picture of what's going on, and then to refer. But as a younger therapist, I used to be really actually quite afraid of specialization. I didn't want to pigeonhole myself. I didn't want to, not be able to treat all the different things, but I've gotten a lot more comfortable with the specialization and just really feeling confident in what I'm treating. I mean, I still have
Yeah.
imposter syndrome even
Yeah.
about
Of course.
the things that I specialize in. So
Same.
there's so much to know. There's so much to learn about treating OCD. I'm sure I will spend a lifetime continuing to
Yes.
learn and continuing to grow in just these areas. So
Yeah.
I can't imagine if I had even more on my docket to learn about.
Right. And as like research keeps happening and things keep changing, I'm going to throw out a bunch of kind of acronyms in a minute here for us to break apart before we get into some of the nitty-gritty stuff. And I'm going to apologize right now. Maggie and I are recording this in mid-January, and there's a lot happening in Minneapolis, and there's a bunch of helicopters flying through St. Paul right now. Uh, that's happening in real time. Sorry for the distraction, but let's talk about, so I was saying how research is going to keep happening, right? And evidence-based treatments are going to keep being shown to like help OCD. What we know now, currently in 2026, is that CBT, like the letter I, and then CBT, which many of us know as cognitive behavioral therapy, right? And then ERP, which is exposure and response prevention, are the two main kind of modalities that are being used. Oh, Maggie, as someone who does this work, I've taken an ERP training and I do not feel equipped to discuss ERP very well. But like, let's break it down. Like, what is CBT and what is ERP?
Yeah. Well, I would want to throw ACT in there as well.
Yes.
I think of it as the big three, kind of a triangle, right? ERP is going to go ahead and be the gold standard treatment, exposure and response prevention therapy. This is, I'm going to use kind of just layman's terms, right? This is really where we systematically we create a hierarchy of feared situations, feared possibilities, and we trigger a fear response in the client and systematically desensitize or habituate. There's a bunch of different theories as to what occurs. Is it inhibitory? Are we inhibitory learning? Are we habituating to it? But essentially, the goal is to get less and less distress as we go up the hierarchy of fears. So, I always use the example of like ERP would be good with someone who was afraid of spiders, right? So the first step might be we just like look at a cartoon image of a spider, right? And for someone who has a specific phobia of spiders, of course, like that is going to even just be distressing. Okay. And so we're going to feel the spike in anxiety. We're going to sit there with it. We're going to response prevention. That's the next part, right? So we're going to not respond with compulsions, and we're going to watch as the anxiety, I like to say, slowly, painfully slowly comes down, right? Like I always like to say, like, it is not going to be a fun time. It's a very difficult therapy to endure as a client. And yet it's so effective, right? That's why it's the gold standard. And there are therapists who say, don't dare do anything besides ERP for OCD because of how effective it is and the fear that something else will turn into talk therapy. But yeah, eventually, so we'd start in that analogy, though, we'd start with that, cartoon spider, right? An image of a cartoon spider. That'd be maybe a 1 out of 10 on the hierarchy. Then, we'd get to 5 out of 10. Maybe it would be we watch a video of someone holding a spider. And I don't know if we'd ever get there, but maybe 10 out of 10, we'd be holding a huge tarantula, right? And have it, walking around our office, right? I've never done an ERP with spiders, but that would be a fun adventure. But you can see how that would be transferable to whatever it is that the feared self is telling you to have those obsessions and compulsions about. And sometimes it's imaginal or scripted exposures where we're starting to, write out, I could harm my child, right? I mean, postpartum, I'm a new mom, so postpartum OCD is on my mind a lot right now. And, I could harm my child and this is how I could, and these would be the consequences. And then we're going to sit with that. We're going to imaginarily expose ourselves to that through our mind, feel the distress, same pattern, watch it spike really high and then painfully slow it comes down. So that's ERP in a nutshell. There's a lot more to it. And then I would say ACT is the other big one. And ACT usually is in conjunction with ERP. And, again, long story short, ACT is acceptance and commitment therapy. And it's all about your values and then committed action. So it goes really well with ERP because it's about what do you care about enough to do the feared thing anyways, right? So back to, motherhood, right? Like, well, my values are being a great mother and a present mother, right? If my OCD is telling me I should avoid changing diapers, that doesn't fit with my values. And so it's about choosing values-based action and committing to living by those values instead of living by fear. And there's all sorts that goes into that, that modality as well, but it goes really well with, I would say, both ERP and ICBT. And then ICBT is the new one that there's lots of fights about in the community. Lots of OCD therapists are like, I don't know about this. And I understand why, because we just want to make sure that therapies are effective.
Yeah.
But I don't know, do you want to hear about inference-based cognitive behavioral therapy?
I think just a tiny bit, because there's also, and I just want to clarify this for anyone who's listening, there's also a CBTI, which is for insomnia. So
yes. Very important.
Because we have so many letters. So many letters. But yes. Real quickly, what is ICBT?
Exactly. Okay, yes. I am not trained in CBTI, although I'm sure I would love to be. I would just be training forever and ever. ICBT is a really powerful treatment, and it is evidence-based. It's important to say it is evidence-based. There's been a lot of research about it. I love ICBT, I have to tell you. I am pro ICBT. I've seen it work again and again. It is a little bit more complicated to describe. So again, there's a lot to it, but if I could sum it up, it's conceptualizes OCD as because of inferential confusion. So inferential confusion, I like to describe, it's almost like we're wearing goggles that, how people say rose-colored glasses? Well, maybe we see the goggles are tinted with fear, right? So we're looking at the world through these fear-tinted goggles. And it's interesting, we kind of dive in a little bit about what might be contributing to how we got these goggles on that are tinted with fear. But essentially, these goggles, we're looking through the world and we're seeing things through this inferentially confused lens, which means we see something and the inference that we make is not what a non-OCD brain would make. In one of the trainings I took, I liked the example. There was a person who comes home and their wife's purse is not on the counter, right? So, and they're just used to coming home and seeing this purse sitting on the counter. That's just where she always leaves it. Well, the non-OCD brain may make a normal inference of maybe she's out shopping. Maybe she is cleaning out her purse in the, bedroom. Maybe she's out, dumping out the purse of all its contents. Who knows? There's so many things, right? Whatever it is with the purse. But someone who has inferential confusion, particularly maybe about feelings of danger or feeling like they're unsafe, feeling like the people around them may be unsafe, they might go, she's been kidnapped. My wife's been kidnapped. That would be the inference that they would jump to because of the goggles that are fear tinted. So that's kind of how I like to think about how ICTB or ICBT conceptualizes OCD. And I consult with someone who's just so amazing, Bronwyn Schroyer, and she really specializes in this and has worked with the creator of ICBT, Frederick Artema, and she really likes to emphasize this normal reasoning versus obsessional reasoning. And really, when it comes down to it, ICBT is going to help us understand that we are not reasoning normally in the way we would with other non-triggering situations. So even someone with OCD, we can access in them the part of them that does have normal reasoning. And we can say, could we in this triggering situation, could we reason with our normal reasoning instead of the obsessional reasoning that's lying to you about how dire the consequences are and the need for the compulsions? So ICBT is really cool because it doesn't just go to the end of the line of the OCD sequence, goes all the way up to the beginning to say, where did this kind of begin? Where's this reasoning process that the obsessional doubt is coming in? And let's target it from the beginning. And the idea being that if the inferential confusion, that obsessional reasoning is resolved, and we go, I don't have to reason that way, then the the compulsions that end up at the end of the OCD sequence, they're no longer necessary. So it's almost like upstream a bit, which can lead to really, really great outcomes long term because people learn this skill and then it can be applied among many, many, many content themes because OCD loves to be like whack-a-mole and like you get one thing and then you're like, I'm good. And then it's like something else, whack it. So ICBT can be really powerful to learn like lifelong skills to recognize OCD's tricks.
Yeah. And correct me if I'm wrong, ICBT also, like, for people whose what ifs melt into reality, like, kind of helps separate that out, right?
And OCD will tell you that any obsession you have is real. That's the thing.
Yeah.
So I would say ICBT really helps differentiate reality from OCD. That's a big, and that's part of that normal reasoning versus obsessional reasoning. What is real? And a big part is that reality sensing of what are my five senses and my inner sense, my common sense. What do they know to be true? And let's use those just like we would in non-OCD situations. And that's kind of where that healing really begins, like at the root of where it all. I find clients really enjoy getting a little bit more knowledge about why do they think this way and what's going on where this does feel really real to me, which ERP doesn't always have that framework of why do I think this way? It kind of assumes, yep, you're thinking this way, it's meaningless, and let's face those fears, which again works really well. It's just a little bit of a different way of conceptualizing OCD itself. And for different clients, I found different methods of conceptualizing their OCD is helpful.
Yeah. Okay. Thank you for breaking those down. I think that's really helpful for anyone who's listening who maybe isn't necessarily familiar with all of the evidence-based treatments or maybe is in talk therapy currently and is like, this isn't working. I need to explore something else. But I want to switch gears and talk about the perinatal postpartum OCD.
Sure.
And I particularly am curious about like also welcome to motherhood. Congratulations.
Thank you.
What a time to raise a child. I say as the mother of a young child as well.
Yeah. It's
but
a little rough right now.
Yeah, like how are we also differentiating between intrusive thoughts and the difference between the intrusive thought and OCD patterns? Like, for example, this, and I've shared this a lot on like previous episodes that I've recorded. When I was postpartum, I had like some complications, but I had a lot of thoughts about putting my hand in the garbage disposal. No plan, no intent, no like if I don't know, there was no like drive behind it that if I don't do this, something bad will happen. It was just the thought of I should go fuck around and find out, essentially. Like, never did it. I have both hands. Like I never did it. But for some reason, that was the thought. Yeah. You should just go put your hand and see what happens. But like, yeah. And then it would go away. So I'm curious, like, how we differentiate that, or is that even differentiated between OCD?
Well, yes. And I actually think that you said the answer within your question because you said there wasn't this, and if I don't do this, something bad will happen, right? So I think it's important for, everyone to know that we all have intrusive thoughts. I mean, I firmly believe if you're like, oh, I've never had an intrusive thought, you're lying. Okay. We've all had intrusive thoughts. One of my first memories of an intrusive thought was like, I was walking by someone in a movie theater and I was like, I just could just like grab their popcorn and eat it. Like, it's just like
Yeah.
so random. And I remember thinking like, what the heck? Like,
Yeah.
that is such a weird thing to think. Right. And that was so like not taboo that I'm willing to share it. But like, I mean, there's a lot of other things I could probably share. I've heard a million things. I mean, what if I was attracted to my dog? What if I mean, we're rewatching Game of Thrones and there's like all this incest, and I'm like, what if I was
Yeah.
attracted to my family member? I mean, it's just intrusive thoughts that again are meaningless, right? They mean nothing. What OCD is going to do is take that intrusive thought and it's going to turn it into an obsessional doubt. So intrusive thought, what if I was attracted to a family member? Obsessional doubt takes it to a next level of what if I'm attracted to a family member sexually and that is real and that means something about me, and oh my goodness, skip to the consequences, all of the horrible things that would happen. I would be outcast, I would be a deviant, it would be an embarrassment, it would be just whatever, right? And then down the sequence to I've got to, perhaps the compulsion in that case would be I'm going to avoid, I'm never going to Christmas again, right? Like I'm not going anywhere, right? I'm not talking to my sister or brother anymore or anyone. I mean, just to avoid that feared obsessional doubt that all started with this intrusive thought. Whereas, I just said that thought out loud. I'm like, what if I was attracted to a family member? And it doesn't stick for me. It's not, for whatever reason, right? That thought isn't going to stick for me the way that it could for someone if their OCD lies to them about that particular thing. So I would say the difference being that everyone has intrusive thoughts and that they're normal, and a lot of times we'll even joke about them, social media or whatever. Oh, intrusive thought about this or that, right? And sometimes they're distressing, right? It sounds like yours was distressing. And I wonder if just the sleep deprivation and the amount of stress that you're under and just the way that the mind changes so quickly in that postpartum period caused an increase of intrusive thoughts. And this one was obviously very distressing. And you're wondering, does this mean anything, right?
Right.
But the fact that it didn't go into, and this means something about me, it could happen, it could cause horrible consequences. That's where I would say there's not OCD present.
Yeah. Which, like, fortunately, as a therapist, I'm aware that nothing further was going on, and also had my child at like peak pandemic time. So there were a lot of factors playing into a lot of things, which, again, as an educated therapist, like, I was very aware that what was happening, right? Yeah. But for people who aren't, and, for new parents who aren't and who experience this, it can be really scary.
Absolutely. Did anyone ask you along your journey? Yeah, that's what that's been my observation from I'll disclaim, I had twin girls 6 months ago. So it's really been really wonderful. And I've been really lucky to have a wonderful postpartum experience. Now, I had a pregnancy from hell. Okay. Hyperemesis, depression, just a lot of just very, very tough physical stuff, tachycardia, blood pressure issues, all sorts of stuff.
Growing one baby's hard, let alone two.
Yeah, two was a little overkill. Okay. I've always been an overachiever. And this time it's
full send. Full send.
Yes. So no, but the pregnancy was hell. And I'll just be honest about that. And so I really want to advocate too, like, pregnancy doesn't need to be fun. Right? Like, doesn't need to be a fun and magical time. But I am really lucky. I feel like the fates or whoever like shined upon me. They're like, you know what? You've been through enough, because postpartum has been really good for me. But I've noticed if it weren't going well, no one would know. No one would know. I mean, what are they giving out, the Edinburgh postnatal depression scale?
Sure.
Like couple
but even,
times.
Right. Filling out the PHQ-9 at your 6-week screener. And mine was probably pretty high at that time, but no referrals for therapy. No, like, nothing.
Yeah.
Fortunately, I finally found a psychiatrist who was like, let's try some meds.
Yep.
To get you back in the right place. And I was like, great, please help.
Yeah. I'm so glad that you found that. I mean,
but I had to do that.
Exactly. If people aren't already connected, it's not going to get found. It's not going to get referred. And again, I mean, at least I guess they're giving a depression scale, but what about OCD? What about, severe anxiety? No one ever mentioned intrusive thoughts to me anywhere. So I just keep thinking through this process, like if I weren't a professional in this space, I wouldn't have any idea.
What can um like individuals who carry children or birthing people look out for? Like, what are some of the signs or the symptoms that they should maybe start exploring more professional help?
Yeah. So, there's a lot of changes go on in those first 6 weeks. And I think a lot of people can experience a lot of different things, whether it be baby blues, they say, right? I know for me, about at sunset every day, there started to just be this dread, right? Of, oh, we're not gonna be able to get the sleep that we need and we want to. And there's shifting, a lot of times there's shifting support from family. There's a lot going on anyways in those first 6 weeks. So I would say just keep an eye out. Of course, reach out whenever symptoms, whether it be depression, anxiety, intrusive thought, whatever it be, please reach out as soon as you find it to be, okay, I could use some professional help with this. But I would say once it gets to be after that 6 weeks, that's where my red flag really goes up of, okay, this is going to be probably a little bit longer standing concern. And so, especially after that 6 weeks, that's where we really want to start getting connected with someone. And as I say it though, I'm like, gosh, probably the best would just be to get connected with someone by third trimester. Just have it in your back pocket. And maybe that's a direction people will start going in, is just saying, I'm going to have a clinician in my back pocket so that they can make that choice of what I might need in that moment. I know being asked to do anything right after birth, it's, you're in such a fog and the sleep deprivation, you're not sure what's normal, what's not. There's all these people in your ear. So I think just getting that would be my advice to anyone, is get connected as soon as you can. And know that if symptoms are lasting longer than 6 weeks, that's where a lot of professionals also will say we might be dealing with something more. And the big ones are depression, right? We hear about that all the time, not feeling connected to your baby or not feeling excited about any part of parenthood. And then anxiety, right? Where it's just, there's just never being able to calm down and get kind of like soothed from that on edge feeling. And then OCD, which unfortunately can be uh, misdiagnosed psychosis, which I think is what's really hard. Of course, there is perinatal psychosis, but
Yes.
it's also important to say that if you're having a thought that you could throw your baby out the window, doesn't mean that you're wanting to throw your baby out the window, right? We need an assessor. We need a specialist to talk through what kind of thought is that? What are we experiencing here? Because unfortunately, moms and birthing parents have been admitted for what's been diagnosed as, a danger to their children, when a mom with OCD is actually just the safest of parents, right? So safe. It's OCD will lie to you and tell you that you are the exact opposite of what you actually are. So that mom where the obsession is, what if I threw my baby out the window? If it's OCD, she's the least likely person to do anything like that. So we just need specific assessment as well.
Yeah. That's helpful information for someone who's maybe unsure of what's happening or where to go next.
Yeah.
But I do agree with you. Like, the sooner you can get someone in your, like, even start meeting with someone or have like some people lined up, the better. Because also, like, being thrust into motherhood it's not easy for anyone, no matter like how easy or non-traumatic labor and delivery and pregnancy are. Like, becoming a parent rocks your world.
Yep. Changes everything. Yep.
Between the sleep deprivation, the hormonal changes, like keeping a human alive, it will rock your world. So having a good supportive person and someone who can maybe help you like navigate some of these changes will be very beneficial.
Yep. Always. Exactly. I would recommend that anyone just get connected for that support.
Yeah. And I'll link Maggie. Obviously, you'll have her information for those of you listening, but we'll also link some additional perinatal supports as well in the show notes for when this airs.
Yeah. If we could link the Hyperemesis Foundation as well.
Oh yeah, sure.
That was a challenge I could not have ever expected. Do you know what that is? Just
like constant vomiting, right?
copious vomiting.
Yeah.
I wasn't even aware that it was a thing
Okay.
until it was happening to me. I was on the highest dose of Zofran and still puking 6, 7 8 times a day. And I mean, what a recipe for just depression and
Yeah.
fear. And it was just a very miserable experience. And I thought, gosh, I didn't even know that this existed, right? So they can be really, that can be a
Yeah.
really helpful resource. I know
Yeah.
they also have a listing of medications to talk to your provider about because they're
Oh,
just
nice.
increasing research about how to help not only mentally, but physically when that is the case for a pregnancy.
Awesome. Yeah, I will definitely link that. Okay, we're really just going to do like a full 360 here and switch to like spiritual, moral, religious scrupulosity.
Yes, yes.
Tell
Well,
the
that's very
listeners what scrupulosity even means.
Yeah. People loved asking me this question. I think it's so fun. They're like, what the heck is that? So, scrupulosity is a form of obsessive compulsive disorder where the obsessions and compulsions are surrounding, oftentimes they can be religious. They don't have to be though. They could be moral. They could be any sort of kind of rule or guide one has for their life. I am increasingly seeing people become scrupulous about political stuff. So even that sort of guiding principle for one's life can we can fall into scrupulosity about that. So, the easiest example though is going to be religion. Okay. So I grew up very, very Catholic, and my knowledge of OCD began with suffering with scrupulosity. So it became the case where the what if questions about my salvation, about my goodness, right? What if I am a bad person? What if I am going to hell? What if God does not love me or God is going to punish me in some way? They became obsessive, and the consequences felt so dire that the compulsions became repetitive prayer, and an enormous amount of going to confession, compulsively reading different texts, reassurance seeking from friends, religious leaders, all of that. And, it's sad because ultimately I think my experience with that is part of what took me away from that particular faith. I mean, there's a couple other reasons why I'm not Catholic, but
Sure.
which we could have imagined what they are, right? But it really was something that was beautiful in my life in many ways until OCD grabbed it and said, this is something that we're going to send you in a loop about. And it's not just, I mean, it's so important. It's not just Christianity. I have Muslim clients. I have just spiritual clients. So just people in different spiritual communities. Again, I have people that are struggling with like liberalism or conservatism, that they're not ever good enough, right? It's not ever enough. And morally, just being a good person, right? And then the obsession being, what if I'm not in some way, and the compulsions being time consuming and distressing, and ultimately not really helping you get back to that value that you actually had in your original moral or faith principle. So scrupulosity is just a really fancy word for that. Latin for like that kind of rock, like teeny little rock.
Oh,
So
sure.
scrupulosity can kind of be conceptualized as like, it's that little rock in your shoe. You're trying to walk, but there's this little rock in your shoe that's like, it's always there, bugging me. So, I mean, I think about, I'm trying to go to church or trying to go to youth group with, people when I was younger, and everyone's having a lovely time. They're not thinking about it too much. They're kind of enjoying the community, the faith, the whatever the benefits were. And there's this rock in my shoe that says, but what if, but what if, but what if? And so that's kind of how I think about scrupulosity. And I treat a lot of people with scrupulosity. It's one of my like specialties within the specialty.
And so are you doing ERP and ACT with that as well?
Yeah. As well, ICBT as well. Yep. Yeah. So it's one of the OCD is OCD ultimately,
Sure.
right? So
Makes sense.
scrupulosity's got a fun other name, but
Yeah.
ultimately it's
It's more fun to say.
OCD, right? And that's a really important point. It's not,
Yeah.
it's important to say it's not a faith or moral issue. It's a mental health issue. And even just getting folks to recognize that is a huge part of the process. But absolutely, I'm doing ERP right now with a Muslim client who we are slowly and surely working up to saying some different pronunciations of different words in the prayers, the 5 daily prayers. And she's just terrified, and because it means the world to her. And OCD attaches to whatever we love most. So if your faith is something that you love and it's something that's important to you, it's perfect ground for OCD to come in and ruin it. But yes, we're doing ERP about that. She's seeing some really good benefits. I've done some ICBT for different types of scrupulosity as well. And then ACT is really great because it's all about values and your commitment to those values, right? So not commitment to arbitrary rules, but commitment to your true values. So assessing what those values really are, and then doing committed action to stay within those values. If you don't treat scrupulosity, you'll likely not be able to practice your moral framework, right? Because it becomes so distressing that it's impossible.
Yeah. Are you finding a lot of individuals are like seeking you out on their own, or have they been kind of like nudged by family members or people in their lives who are like, this is maybe going a little further than is healthy?
It's really both. I get a lot of referrals through the International OCD Foundation where people just have looked me up and they see me there, or from referrals from their therapist. I get a lot of referrals from other people's therapists who have said, you know what, I know of this girl and I think maybe you could get assessed, at least just get an assessment from her. But I do definitely see people come in where they say, I don't know, but my family says this is too much. I don't know if it is. But the thing is that I find that less and less because people know when there's something really distressing, right? Like OCD is ego dystonic. It is not, it feels out of line with who you are. So dystonic meaning here's who I am, here's what I value, here's what I want to be. And OCD is not that. We can see it as like, this is getting in the way of who I am. So most people know that there's an issue and they just don't know how to get past it and get through it.
Okay, where is a good place for people to start? Like to either find a provider, to find resources? I know you mentioned a couple, like the Hyperemesis Foundation and the OCD Foundation, but where else can people start to begin to navigate this?
Yeah. So, if you're struggling with anxiety or OCD, I would get an assessment by a specialist. So, that would be my first resource would be look up a specialist in your area, especially if it's OCD that we think we're dealing with. A specialist is going to be so necessary. I would look to the IOCDF, the International OCD Foundation, first for that. There's listings of thousands of providers throughout the country, as well as support groups and treatment groups. And I would just really go that route. Worst that a specialist can tell you is, hey, you know what? I don't think you have OCD. And here's where you can go, or here's what we can do. But oftentimes if you're getting to that point, you probably could have some things where a specialist could help. Yeah, Hyperemesis Foundation, Postpartum International. There's so many good resources there. So that's where I would lead people, but also just getting connected with a human being, a professional counselor, therapist in your area who can direct you to resources that they know of. If they can't help themselves, we'll direct you to resources that will be helpful. That person-to-person interaction is just so important.
Yeah. I feel like too here in Minnesota, we have a very solid base of like perinatal, postnatal providers and now OCD providers. Like I feel like those two kind of specialty areas have really grown, and the people I know within those communities who are like the clinicians are so knowledgeable and so well trained. So if you're local to Minnesota, that's, a plug
Absolutely.
for
And you
that.
know what, too, though, we have a lot of interstate national groups as well. We have tons of Facebook groups just for us clinicians to talk to each other around the world. Honestly, I consult with someone from the UK once a month. So, even if you reach out to someone and say, I need an OCD therapist in, Pennsylvania, it's
Find it.
likely that we can find someone for you, whether you need someone who's private pay insurance, whether you want to do virtual or in person, just reach out and start asking those questions and get the care that you need.
Yeah. Where can people find you or learn more about you?
Well, I was telling
So
Ryan
we're just talking.
a bit earlier that I'm likely to be rebranding my business in a bit, just so that there's not confusion between myself and another business locally. But I would say the best place to find me right now, my website is Northlight Counseling, Northlight, one word, counseling.org. If you go there, likely I'll have it rerouted to a new website soon. But you know what? You can always find me by searching Maggie, MaggieDuret. And I'll always have that Psychology Today page open that will direct you to wherever my business page is. And I'll be around. Nothing's changing. Maybe a name change, but I'll be around locally in St. Paul and throughout the state of Minnesota virtually.
Yeah. And this will air in like 8-ish weeks. So for those of
Maybe
you who
I'll know
will be
by then.
listening when it airs, everything will be linked in the show notes. So I'll still stay in touch with Maggie to make sure.
Together.
Yes.
Yeah, we'll all find out together what my new business name
I'll
is.
celebrate it with you.
Exactly.
And then everything will be linked in the show notes. The resources that Maggie talked about will be linked in the show notes, so you can also check those out. Any final thoughts for the listeners as we wrap up?
Oh, man. You would think that I would have thought of a final thought. You're not alone. Whatever you're thinking, whatever you're feeling, you're not alone. Someone has thought it before. As OCD therapists, nothing shocks us. I mean, we just have truly heard it all. Reach out, tell someone what's going on in your head, and let them help you, let them navigate it with you, let them direct you. But there is no reason to go through life alone. So tell someone what you're going through.
Thank you for being here, Maggie. I appreciate it. It's been a pleasure to have this conversation with you.
Yeah, it's been an absolute pleasure and an honor, Ryan. Thank you so much.
Thank you for listening. I hope you enjoyed today's episode. If you want to learn more or follow either of us on social media, you can find more information in the show notes. Thanks for your support and listening, and I hope you have a wonderful day.